Welcome to Trinity Health IHA Medical Group Wednesday Wellness Series. This presentation is titled Skin Cancer, an Overview, When Good Skin Goes Bad. And our presenting provider is Trinity Health IHA Medical Group Primary Care Physician Matthew Moore. Dr. Moore practices family medicine at our newer practice in Saline. Family medicine means he sees patients of all ages from newborn and up. As a primary care physician, Dr. Moore has diagnosed and treated a number of skin cancer cases and is here to talk about the different types of skin cancer and the most important things you need to know about the prevention, warning signs, diagnosis, and treatment of skin cancer. Welcome, Dr. Moore.
Thank you very much. I appreciate it. And thank you so much for everybody for joining us today. I'm very happy to answer any questions you guys have. I do see one already that's been posted there, but we'll get those things at the end. So I was asked to come give a topic on anything, talk anything I wanted to, and as she mentioned, I do a lot of skin cancer treatments, and so I thought this might be a good thing to be talking about. So I would want to talk about when good, like I said, when good skin goes bad here. So we'll go ahead and get started. So I always like to make a little bit of a joke made by Johnny carcinoma. The basal cell carcinoma or squamous cell carcinoma. So we can talk about Johnny Carson, but actually it's a bad pun, but he did actually have basal cell cancer. But the skin cancers are some of the most common cancers in humans. And so it is one of the reasons we really need to pay attention to these. So, talking about skin cancer, what is it? Where does it come from? Well, it's basically an uncontrolled growth of it's an uncontrolled growth of abnormal skin cells. There's several different types of skin cells. If you want to think of it as, people talk about skinning off the top few layers of skin, and then there's the bottom layer of skin or what have you. This sort of gives you an idea. There's a few different kinds of skin cells there, and then there's also skin cells that give you color, the pigment that's there. And some people have more than others. So there's basically, for lack of a better term, three major types of skin cells that we'll end up talking about here. The skin cancer is uncontrolled growth of those skin cells. And the skin is actually the most common organ to get cancer in. So we need to be careful about that. But the great thing about skin cancer is most have a 90% or even greater than 90% cure rate if you catch them early enough. And so we need to make sure we are doing good for detection, and we'll go over that here as well. How to notice one, and what to do in terms of talking with your doctor. So in terms of the three different types of skin cancer, we have basal cell carcinoma. Basal cell carcinoma is basically the base layer of the skin, sort of where the skin meets the dermis underneath. The epidermis meets the dermis deeper down. We have squamous cell cancer, which is a little bit higher up in the food chain, so more of those top layers of skin there. And so they're it's a much harder, firmer type of cancer in general. And then, of course, we have the bad one that everybody knows about, which is melanoma. That's the one of the pigmented skin cells. And we'll be talking about that one as well, of course. Now, that being said, to go back for a second, those are not the only types of skin cancer. Those are the most common types of skin cancer. But those three there probably make up greater than 95% of all skin cancers. And that's why we're going to be focusing on those. So, what are the risk factors for skin cancer? What do we have to worry about? Well, exposure to UV light is the main risk factor for skin cancer. Obviously, the sun, but tanning beds can be pretty significant there as well. As a matter of fact, with the increased use of tanning beds, we're removing skin cancers on younger and younger people, even some in their 20s and 30s, which is pretty unheard of back quite some time ago. Both the sun and tanning beds have UVA and UVB rays. The difference there is both of them can cause skin cancer, but one causes more aging and the other one causes more sunburns. And so, 20, 30 years ago, when we all had our Bain de Soleil sunscreen and everything that we'd use, or the stuff that always smelled like coconut that my dad would get us, there was like an SPF of a whole 4, not very much, but that was usually just covering one of those type of UVB rays. Over time, we found that the UVA rays are also quite dangerous in terms of skin cancer. And so now you have broad spectrum sunscreens, and we'll talk more about those in a little bit too. So if you've had a history of a bad sunburn, I think most of us have had a history of a bad sunburn, especially if it was a blistering type sunburn. That'd be something we'd be more concerned about, in terms of a risk of developing skin cancer. A history of greater than 5 sunburns lifetime. I don't think I've met a single person, at least in Michigan, who hasn't gotten more than 5 sunburns lifetime, because we all want to be outside when the sun is out, and we don't always remember to put the sunscreen on. Having a fair skin, lightly colored eyes, or easy burning. My wife does not like going out in the sun very much at all, because she goes from white to red. She does not have any tanning in between. My brother-in-law used to always go and put a towel around him whenever he'd be outside, even over his head, just to make sure that he didn't get any exposure because he would burn very easily. He had a family history of someone dying from skin cancer. So you just have to be careful if you're a person of fair or Celtic origin. I always tease my patients that have nice, beautiful red hair or fair skin with freckles, but that might be a risk factor for them. Speaking of freckles, freckles is also a risk factor, as well as having many moles. Multiple moles is more of a genetic condition that some people end up having. And it's not that the multiple moles necessarily are bad, but if you, and I'm just making numbers up here, 1 in 100 is likely to turn into cancer. Well, then if you happen to have 100 of them as opposed to someone else who has two, you're more likely to have those turn into cancer. So you just need to keep a closer eye on someone who has multiple moles. Genetics obviously plays a role as well. If your mom or dad, brother, sister had skin cancer, you're more likely to have skin cancer. Once you get further away than mom and dad, the risk does go down, although the rest still is present for second degree relatives. And finally, of course, previous skin cancers or pre-malignant lesions, precancerous lesions of the skin. And we'll talk about those as well. Because obviously, if you had a skin cancer here on your nose, well, that probably got about as much sun as the side of your face did. And so, the chance of getting a skin cancer in another place are relatively high. So common locations that people will have for skin cancer is basically wherever the sun hits. Scalp, like I teased about myself about, gets a lot of sun. Your ears, especially the top of the ears, need to be worried about those. But also the flat part on the inside here gets a lot of sun. The face, of course, the nose, the eyebrows, basically wherever there's a shelf that the sun can hit. So if it's raining and it's more likely to hit that spot, your nose, your eyebrows, your scalp, your ears, as opposed to your eyes, under your nose, under your chin. Those areas are a bit shaded, so you don't have to worry about those quite as much. Your shoulders, obviously, if you especially if you're wearing you're not wearing a shirt or you're wearing somewhere like a tank top. Your hands, just because they're out and doing stuff all the time, the sun's coming straight down on them for a lot of the time as well. And your back, because generally if you're outside gardening or digging a ditch or just playing around playing baseball, whatever, you're bent over and the sun is beating on your back. And but then also, of course, the top of the feet. Again, it's a flat spot that the sun can be pushing right down on and getting you a lot of UV rays there. So the first thing we're going to end up talking about is not skin cancer, but a precancer. These are called actinic keratoses. Now, these are also known as AKs for short, in case anyone ever brings that up. Just so you know what doctors end up talking about. We doctors don't do a great job translating medical into human speech, and so just try to give you a little bit of a hint there. If someone's talking about AKs, that's what we mean. But these are basically precancerous growths of the skin. Now, let's see if I can get my mouse here. So I'm not necessarily talking about these brown spots here. They tend to be more actually flesh or pink colored, and these are, potentially some in here. And generally they feel rough like sandpaper. A lot of times you can feel these before you can actually see them. They can be pink, they can be red, they can be white, they can be brown as well, but they tend to just be sort of a rough spot that you can feel more than see. It has the exact same risk factors as skin cancer, and they, as I said, they since they potentially turn into skin cancer, they would make sense they have the same risk factors. And in this case, actually, I'm used that as an example earlier with moles, but for this one specifically, every year, each one has about a 1 in 100 chance of turning into skin cancer. So if you have one, it's a 1 in 100 chance that year. But if you have 10, well, each one has a 1 in 100 chance. So, it's not quite 10%. That all involves math, and that'd be more to my brother to talk to than me with that. But my point is that if you have multiple ones, your risk does go up with that whole thing. Um, Now, the good news is these are relatively easily treated. They're not deep. They're very superficial type of lesions. And so people are pretty familiar with us using a freezing spray with these. So the common one being liquid nitrogen. Liquid nitrogen is roughly negative 300 degrees Fahrenheit. So that's pretty darn cold. And we spray it on the skin, or we use a Q-tip to apply it to the skin or what have you. It causes basically localized frostbite in that little area that we spray it or apply it with the Q-tip. That causes it's like putting a can of Coke in the freezer. The skin, so the water expands. That causes damage to the skin. It can sometimes cause a blister, but basically it causes damage. Then the white cells come in. They realize that something's not right here. They clean things up, and you get some new skin that forms in. Sometimes it has to be treated more than once, depending on the extent and the depth of them. But that's what the freezing is about. With the chemical burning, those are other things can be used. There are some lotions and things like that that we can prescribe. 5-fluorouracil being one, and oh, I'm forgetting the name of the other one that I use. I use it all the time. I'll remember it by the end here. But there are some chemical treatments that we can use to make this go away. And then the other thing, of course, we can do is a biopsy. I mean, if you cut it off, you technically make it go away. I try not to do that too much for these types of things because, eventually it can look like you got in a knife fight if you end up doing too many of these as a biopsy. But you try to, treat them with the least invasive and least destructive version possible that is effective and does the job. This is a little bit more obvious in terms of actinic keratoses. You have these red spots here on the face. These may be turning into early squamous cell cancers here, but you can see these red skin. You can imagine when you rub your finger over them, they feel pretty scaly. So in terms of identifying them, they could be gray, flesh, or pink colored lesions. They're pretty localized. The surface of the lesion can be flat, but it also can be sort of rough. Just because it's flat doesn't mean that it cannot be elevated a little bit. It becomes rough like sandpaper. And they can sometimes become wart-like, almost look like it's growing little fingers out of it. That's called a filiform wart. Fila meaning finger, form meaning shape. So finger-shaped warts, when the little fingers look like they're coming off of a wart, like when people have a wart on their nose, their cheek, or something like that. Their lips sometimes will look like those. Here are some more pictures of these things on somebody's scalp. You can see this is sort of brownish and raised up. So, these can come in a wide variety of colors and presentations, but the scalp and the face are some of the most common spots, and the hands. But like I said, they can show up on the ears and the shoulders, tops of the feet, a lot of other places as well. Moving on to our first cancer, we'll talk about basal cell cancer. This accounts for almost 75% of all skin cancers. So this is one of those things that we really need to pay attention to. And now you have all those top layers of the skin. And remember, this is the base layer. This is the layer between the top layers of the skin and the deeper skin underneath. And these types of cancers tend to develop very slowly. So that's good. And we obviously don't want something that's too aggressive and developing quickly. But these can frequently ulcerate. So if you see a spot, a skin lesion, and you start to notice a dimple in the middle there, and it's bleeding or it's draining a little bit or something like that, looks like a sore. This is the type of cancer that we'd be thinking about. And just because it has a sore to it doesn't mean that it has pain. It looks like it should, but it doesn't necessarily. And so it can be a painless type of ulcer. So the basal cell cancers, again, where the sun hits most, is most likely where you're going to get them on the face and head and neck are the common places for that. The great news about basal cell cancer is the chance of them spreading somewhere else is very, very low. Less than 1% of all these skin cancers will metastasize and go somewhere else. So they rarely end up hurting somebody other than local damage to the skin. Now, that doesn't mean it can't look like got in a knife fight and someone took a chunk out of you because of what they have to remove from where the skin cancer is. But the chance of it leading to somebody's death is very, very low. The Dr. Mose, who developed the Mose surgery, he always said, I didn't cause the problem. I just removed the cancer that was there. What's left is, that if someone's missing part of an ear, that was the cancer's fault for being, because that's where it was. It's not because that's what I tried to do to them. If you catch these early, they have less chance of having any disfigurement that may end up happening. And so these are very highly curable if caught relatively early, and 99%. So these do very, very well. The symptoms of these is a sore that changes, or sores that don't heal, or they keep recurring again and again. It heals, then it comes back, then it heals, and it comes back. A crater-like ulcer in the skin that might not hurt, as we talked about before. A change in color over part of the skin. Generally, it's associated with one of the other pieces above it there, or a raised area of skin. They tend to bleed. So with these being a cancer of the base layer of the skin, what ends up happening is that base layer holds the deep skin onto the skin above it. And if that cancer is there, it basically is an abnormal functioning piece of skin. So it's not really connecting the lower layer to the upper layer, and that's why part of the skin comes off and develops an ulcer. That's why it's more prone to having bleeding, is because you're much closer to the blood, and so it can with the lower layers of the skin, so it can start to bleed from there. It can cause itching. So itching in the skin can be a sign of something growing. When something is starting to grow in the skin, is pushing the skin around it, it can lead to an itching or a stinging sensation. And so an ulcer or a skin lesion that itches is a concern and something should be checked out. Pain, although as I said, it can be a painless ulcer. Just because it can be painless doesn't mean all of them are painless. So there can be pain associated with this type of lesion as well. And here you can see this sort of has a bit of an ulcer right here, with a little bit of redness around it. Looks like it's trying to heal, like you had a normal scab. And this could be a normal scab, if we didn't know it was a basal cell cancer, but you would expect it to get better and go away. The hallmark of a basal cell cancer is it doesn't go away, or it comes back again and again and again in the same spot, because these cells are abnormal, and so these top will fall off and it'll heal, and this will fall off again because it just can't hold on to it. Over here again, you're seeing a couple of spots that are likely skin cancer. Here are basal cell cancer. Sometimes you'll see a little bit of a raised edge. It's just sort of a little easy to think of it here, just because you got the dimple in the center here too. But a little bit of a raised edge. We call it sort of a rolled border, and it can also look a little bit pearly in its appearance. So, in terms of diagnosis and treatment of this, the diagnosis is made by a biopsy or possibly by a doctor's exam. Biopsies, there can be several different types of biopsies that we can do for that, and we'll go over those later. But biopsy can make the diagnosis, but also can sometimes be the treatment. Just down here, surgery. When I say surgery, I sort of mean a biopsy. But it's a minor surgery that's done in the doctor's office. Now, basal cell cancers can be treated in other ways as well, but it depends on where it is and sort of how long it's been there, how aggressive that basal cell cancer is. But some of them can be treated with burning. So, you can do that with electrocautery. You can sometimes do that with heat potentially. You can be treated with freezing. Now, that would be like the cryotherapy, the liquid nitrogen that I talked about before. Then there's surgery, which is probably the favorite option there, just because it's pretty darn definitive and the thing is done. Then you can also use chemotherapy, which is a lotion you can put on there. Aldera is the other medication I couldn't think of off the top of my head. That is a chemotherapeutic agent that you can put on these things to help clear them up. Or actually, you can use radiation. That's a pretty specialized use of radiation. We don't really do that so much anymore. Back years ago, back in, let's say, the 40s or thereabouts, maybe earlier than that, they used radiation as a way of treating teen acne. It worked great, but then it led to a lot of skin cancers later, as well as loss of bone in the jaw and things like that. So we don't like to do radiation any more than absolutely necessary, because while it might fix the problem, it also might lead to more problems later in terms of other skin cancers and the like. It's also pretty expensive compared to everything else we can do. Skin cancer, I said, it's one of the most common cancers out there. So just go over a small list of people with skin cancer, and most of these are basal cell cancers these people had. You can be a politician, Ronald Reagan and Bill Clinton. You can be an entertainer like Johnny Carson. You can be Cleopatra, like Elizabeth Taylor. James Bond, Roger Moore had plenty of those. The X-Men, Hugh Jackson, he's Wolverine. He's supposed to heal up all the time, but nope, he got skin cancer too. You can be a musician. Jimmy Buffett died from Merkel cell skin cancer. It's one of those different odd types of cancers, but it's a lesion that ideally could have been caught and treated earlier. You can be a Super Bowl winner like Terry Bradshaw, singer of Poison, like Brett Michaels. Say Poison? I don't think he was. Wait, I'm sorry, I might have the wrong band there. I apologize. You could be a newsman like Anderson Cooper. So pretty much, cancer doesn't really care who you are, doesn't care what political party, how famous, or anything like that. Anybody can get skin cancer. You can be Superman's mom. Diane Keaton got it, or Obi-Wan Kenobi. Ewan McGregor had it. So it pretty much is an equal opportunity cancer. So moving on to the next cancer we talk about, this is squamous cell cancer, or squamous cell carcinoma. This is more of the upper layers of skin. It tends to be more of we call it keratotic, but it's more of the dry, hard skin. Nails are made of keratin as well, but not necessarily like a nail. My just point is that it's going to be a little more of a hard nodule type of thing in general. So in terms of the risk factors, these are pretty much the same risk factors, but smoking is added in here as well as the use of petroleum products. Not so much Vaseline, but people who end up doing a lot of work in shops where they have to be putting their hands in solvents and things like that can be an increased risk for these things. These can occur everywhere, but usually happens on the lips and the face. I have removed those from the back of people's hands as well. They can get pretty significant in size sometimes, and sometimes relatively quickly, but just something needs to be an eye kept on and look out for. These can metastasize about 20% of the time. So they do metastasize a little bit. Generally, when they do metastasize, it's a local metastasizing. So it just goes to a larger area than you can see with your eye, as opposed to jumping to the brain or liver or something like that. These are also very curable if caught early. If you catch them early enough, they do have like a 90+% cure rate. Symptoms of this would be, again, a sore that changes in the skin or doesn't heal, a crater-like ulcer that may not hurt. Unfortunately, as you can tell, a lot of these things have very similar symptoms. A change in color of the part of the skin, bleeding, itching, pain. And you can see here, there we go. This has a little bit of an ulcer here, but it's also a little more raised up. This one is definitely more raised up and has a little bit more, well, not just pigment, but a little bit more substance to it there. So things we just need to keep tabs on for those types of lesions. Here and here, this one looks like it's ulcerated a little bit as well. It's sort of wet, but if you can imagine that this is being dry, it sort of has an elevated spot that can be pretty hard, almost like a wart. And same thing similar up here. For diagnosis and treatment of this, again, a biopsy can be a good diagnosis for that. You'd get a small piece of it, and we call that a punch biopsy, just like a 3-hole punch is only like a 3 millimeter circular spot you take out. You numb it up first because we're not mean, and then we go ahead and use that 3 millimeter piece to scalpel. That's just a circular scalpel to take a little piece out of there, snip it off, and it's actually so small that the biopsy is so small it doesn't even require a stitch. You just put a little triple antibiotic on there or Vaseline and a bandage over it, and you're good to go. And it'll heal up on its own without any sutures. So our doctor's exam, obviously, if it's a classic squamous cell cancer, you can pick it up from there as well. The treatment for this is the exact same pretty much as for a basal cell cancer. Sometimes you have to be a little more aggressive in terms of how long you treat it or how wide of an area you remove. But squamous cell cancer and basal cell cancer are very similar in how you would end up going about treating those. Some famous people with squamous cell cancer: Rebus Philbin, George Washington, George W. Bush, George H.W. Bush, and this tends to be a less common, well, less publicized type of skin cancer than basal cell because it is so much more. Basal cell is so much more common. The final one that we're going to talk about here is melanoma. And this is the bad actor. This is the one that nobody wants to have. These are some examples of melanoma, and we'll go over the symptoms here in just a little bit. But this is the most lethal type of skin cancer. It has about a 95% cure rate if it's only local invasion, but local invasion, I believe, is 2 millimeters. It can't penetrate more than 2 millimeters from where it's normally located if you want to have the high cure rate. It's a lot less curable if it metastasizes, and this is the type that will metastasize far and wide, and can be very, very challenging to treat. As an aside, when I was working in Grass Lake, I had 2 business colleagues pass away from melanoma. The first was my fishmonger. Actually, he was here in Chelsea, in the Chelsea market, and his first symptom was he didn't have a skin spot that he saw. He had a seizure because it had spotted jumped to his brain. So he had no warning of it coming. The other one was an insurance salesman that I were friends and business associates, and still see his family on a regular basis. But he had a skin lesion that the doctor removed, and it was not well. Some spots are challenging to find where that kernel is, and we'll to talk about basically how you cut up a spot. So if I took the spot this big off, basically the pathologist cuts it up like a loaf of bread, which is so you can look at different pieces on there. Well, as you can think of, if you have raisins in a loaf of bread, if you are cutting up that loaf of bread and you hit one side of the raisin and the other side of the raisin could be in the middle and you can never see it. So there can be a sampling error with those types of things. So we just have to be very, very diligent about making sure we communicate with our pathologist all the time. But they think that's what happened for him, is that there was a sampling error with the piece, and a couple of years later he ended up with a lump on his neck, and he ended up passing shortly thereafter, and he was only 41 years old. These share the same risk factors as other skin cancers, so I don't need to necessarily go over all those again. They can actually show up in odd places. Not that I expect you to find it in these places. You're not going to find one in the back of your eye, but it can happen in the retina. It can happen between your toes. So my point here is being that you can get melanoma sometimes in areas that don't get a lot of sun, and even under the nails. A lot of times somebody starts to develop a black line that starts growing out on the nail. That's when we would start to look at that. Now, there's other things that can cause black lines on nails that are much, much more common. So I don't want everybody who has a black line streak coming out their nail think they've got melanoma, but it's worthwhile to ask your doctor or dermatologist to make sure that that's not what's going on there. And obviously, as with everything else, sun is a major risk factor, but it's not the only one. So looking for melanoma, what things do we look for? Well, we talk about the first actually six letters. I know this one has five. There's an F that I would add to this. So what you're looking for is the A, B, C, D, E's. A stands for asymmetry. So can you cut this lesion in half? And if you folded it over itself, would you actually would it fold over perfectly, or is there a mismatch there? And then I would also argue that seeing if you could cut it in half this way, because obviously you don't always get perfectly circular moles. You sometimes get oblong shaped ones like this. So can you cut it across, up, down? Can you cut it across left, right? And if you can, then that is less concerning. The border, does it have a nice sharp border like this, or does the border look like it's ragged edges, or does it look like it's grown, just sort of fading into the skin? If that's the case, then maybe something's growing down and deeper that we just can't see. So what you like is a nice sharp border. C is color. One color good, multiple colors is more concerning. You basically want everything to be nice and boring in terms of any lesions to make it so that the more creative it is, the more concerning it would be. So for a diameter, you're looking at greater than 6 centimeters. Sorry, 6 centimeters. Ooh, that'd be big. 6 millimeters would be concerning. And for that, we think about roughly a pencil eraser. If it's larger than a pencil eraser, it's more concerning. If it's smaller, it's less concerning. The E for this mnemonic here is evolution. That's probably the most important one. Is it evolving? Is it changing? Is it growing in size, changing in shape or color? Because things that are changing are much more concerning to be cancer than things obviously that are staying still. The last one that I would bring up is F, and F stands for feeling. Do you feel it itching? Do you feel it burning? Do you feel it stinging? If that's the case, as I said, when something in the skin is growing and stretching the skins around it, you can get those types of sensations. So I think I might have all those right here. Yeah, sharp or blurred, one or multiple, elevation, and elevation just being, is it high and is it one flat elevation, or does it go up, down, evolution. And I'm gonna go back up here one more time. So I talked about all these letters that are skin. We'll talk about skin cancer, and I didn't try to say. I tried very hard not to say, if it has one of these, that's bad, or it's skin cancer or something. Each one of these increases the risk of it being skin cancer, but it doesn't mean that it is skin cancer or is melanoma. What it means is it has an increased risk of being melanoma, and it's more likely you should have it looked at. I've had people who've come in to see me with all six of these things, and it wasn't melanoma, and they were fine. We took it off just because it was causing them problems. If the stinging sensation was annoying, but it was not melanoma, and they're doing fine. But I've also had people that a lot of these things look sort of normal, and it was melanoma. So we just have to be very diligent about keeping eyes on things. And if something just is not acting quite right, we go get it checked out. So more things to look at for melanoma is, of course, a mole that bleeds. If it's abnormal cells, the abnormal cells are more likely to be friable and bleed. A mole that grows quickly, that could be a concern. A scale or crusted growth in the skin. This one up here is the melanoma here. Now I had seen other things like this that are not melanoma as well. But if you're seeing something like that, you should at least get checked out. A sore that won't heal, like this one up here, just came back again and again and again. It looked like it was going to get better. It scaled over, and then it just opened up again. A mole that itches, as we talked about before, a place that feels rough like sandpaper. And for a melanoma in general, I would be wanting it to be something that does have pigment to it and being rough, and the pigment being very brown, like that one. There are some things that can look like melanoma that are not. This is not the best picture of what's called a blue nevus, but a blue nevus tends to be a well circumscribed, so it's nice sharp border, symmetric lesions. You can cut it in half this way and fold it over, it looks fine. You cut it in half this way, fold over, it looks fine. It tends to have one color, but that color is bluish. This has a slight blue hint to it, but sometimes it can be pretty remarkably blue, bluer than the veins that you have in your skin. And the diameter tends to be relatively small, like these are. But blue nevus can mimic a basal cell, sorry, a melanoma, and then also probably the most common one are dysplastic nevi. Nevi just means mole. Dysplastic means abnormal. We got to use our medical terms somehow, whatever. But these are precancerous, and a lot of these things are precancerous moles that it's got some. It has like this one's not symmetric. It does have a relatively sharp border, and maybe not so much on this end. It does have a one color, although there's some maybe a little bit of lighter color in there as well. The diameter, we don't have anything to compare it to, but its diameter is probably bigger than we'd like it to see. It is these things do tend to be somewhat heaped up. I don't have any symptoms. I can't tell you what's got us having any itching or burning or anything like that. But these would be things we would worry about. And for those, we can do a biopsy of them. Things also on this that can look like this are called seborrheic keratoses, which are sort of those barnacles you see people grow sometimes. There's those tan things there on there, like look like wax. And if you almost get your finger underneath there, you can just sort of peel them off. They can look similar to this as well. And those are not cancerous at all. They do not have any, no more likely to turn into cancer than any other spot on your skin. So in terms of diagnosis of melanoma, really let me see. Did it stop working again? Oh, there we go. Okay. The only way to diagnose this really is a biopsy. Now, we can use this fancy microscope here. This is called a dermatoscope. Dermato meaning skin, a scope meaning, something to look with. It has a magnifying lens in there that can magnify by 3 to 5 times, so we can see things better. It also uses a polarized lens and polarized light. It's this one's being used on a very close method, how to look for skin cancer. But when fishermen go out and fishing, they like to wear polarized sunglasses because it stops the reflection of the light off of the water, and they can see under the water and see the fish better. The same thing is true in your skin. A lot of the light that hits your skin gets reflected off the top layer. So you can't see underneath. You can't see the pigment cells of the skin. You can't see the blood vessel patterns. You can't see if there's scarring or other things going on underneath there. So by using a polarized light with then the polarized lens there, you can get a good idea of what's happening underneath the skin there. I have one of these dermatoscopes, and I think it works wonderfully. It does not make me diagnose more people with skin cancer. It actually helps me diagnose fewer people with skin cancer because it can give me a significant amount of reassurance. And if I have reassurance, I can say, let's just follow that. Whereas if I didn't have this piece of equipment, you end up looking at things and you have a big question mark in your head as to whether it's concerning or not. And so you go ahead and take it off. In general, the rule is when in doubt, take it out just to be certain, especially if you're worried about melanoma. But like I said, this instrument definitely does help me take fewer pieces off into entirety. In entirety. Yeah, sorry. So what is the treatment for a melanoma? Well, for a melanoma, it has to be a wide excisional biopsy. So what do I mean by wide? I mean, if however big your lesion is, you're taking at least a centimeter on one side and a centimeter on the other side, and then you're probably making that into a football shape in terms of what you're taking off. Sometimes also, depending on how advanced the melanoma is, they'll inject some dye around the melanoma. They will follow that dye with radiographs to the lymph nodes, and they'll maybe take out a couple of those lymph nodes to see if any of that has spread to the lymph nodes as a way of trying to help see where things are at. Um, if things have gotten away from the local area, there is some chemotherapy. They've gotten much better with chemotherapy treatments. By much better, I don't mean they're great by any means, but they are much better than they were before. And a lot less, a lot fewer side effects than there were before, but still more progress needs to be made. And then radiation is another thing that we can do, although melanoma does tend to be fairly resistant to radiation. And the prognosis really depends on the stage. Obviously, I'm sure you're all familiar with cancer, stage 1, 2, 3, 4. The further along you go on the stages, obviously, the worse it is, and the harder it is to treat. That's because the cell of that cancer has mutated more and more, and it stops responding to the normal things that cells will respond to. It just stays within its own world and keeps doing its own thing, so it doesn't respond to the chemotherapy agents quite as much, and it gets more resistant to radiation as well. So famous people with melanoma, FDR and Eisenhower, Troy Aikman, Bob Marley, he actually died at a young age from melanoma. And then John McCain also had melanoma. So don't think sing Sinatra and say, I've got you under my skin. You want to make sure you catch it early. And that involves you looking for it and having your doctor help do skin exams. So in terms of trying to prevent skin cancer, there's a few different things that we can do to try to help prevent skin cancer. Yeah. First thing I would say is don't do it to yourself. No tanning beds. I know people like to also say, well, I'm going to Florida. I'm in Michigan. Understandably, it's February and you want to get a base tan before you go down. That will put you at increased risk, potentially of getting skin cancer. Obviously, you get a bad sunburn. You could argue that, well, if I go down there and I don't have a tan, I'll get a sunburn and that'll put me at risk for skin cancer. I'd more recommend making sure you're properly and frequently applying sunscreen as opposed to using a tanning bed as a preventative. You want to use a broad spectrum based sunscreen lotion. So it will say broad spectrum. You might even see it say on there UVA, UVB protection. And so we're trying to block UVA and UVB light, both of which can lead to skin cancer. From an SPF standpoint, you want to be using somewhere between something greater than 15. If you get above 30, I mean, that's fine. For me, they tend to just get really goopy and thick, and then you're like your Casper the Friendly Ghost with because you can't really rub it all in. Actually, you can now get pigmented sunscreen, so that way it doesn't look quite that bad. But what SPF 15 means is you can be out in the sun 15 times longer and get the same amount of UV light. So it would be the equivalent of saying, okay, well, if you spent the time 1 hour in the sun without suntan lotion, or 15 hours out in the sun with suntan lotion. That's pretty good. If you use 30, you're blocking 29/30ths of all this UV light. So you're basically getting what you're blocking 96, 97% of all UV light. You double that to SPF of 60, you're not really blocking that much more light. From 97%, you can go to 98. I think that technically is better, but is it if it's goopy and kids are not going to wear it, or you're not going to want to reapply it, is it really helping you out? So I would encourage to use between 15 and 30, or something higher that is in a formulation that you're going to not have a problem with. So before I go on to that, just talking a little more about sunscreens. If you have sensitive skin, the zinc oxide or titanium dioxide, they're mineral-based sunscreens are probably the best for you. And when you look on the active ingredients, it'll say zinc or titanium oxide on there. So the way I remember that is if the first words are on the periodic table of elements from chemistry class, that one's okay. The other ones have really long chemical names that no one can pronounce. And if you see that, I'm not saying they're bad, they work absolutely fine. But if you have sensitive skin, those tend to be a little more irritating than the mineral-based ones. Let's see. And then with the sunscreens, you should be trying to apply every 2 to 4 hours. You're looking for basically a tablespoon for your face and basically a shot glass for the rest of your body in terms of the amount that you should be using for those. You want to avoid sunlight when the UV light is at its most, so 10 to 4 p.m. I'm thinking about it being daylight savings time. Really, it should be 9 to 3, but with daylight saving times, everything shifted an hour. You're looking at 10 to 4 p.m. 10 a.m. to 4 p.m. And of course, clouds, we like to think it doesn't cause a problem, but they really don't do a great job of blocking UV light. There is some protection there, but it's definitely not the protection that we think that we should have. Yep. Let me make sure I didn't miss anything. Nope. Okay, good. So wearing long sleeve shirts, wide brimmed hats. There are some shirts and hats and things that are specifically designed to be UV blockers that for people who are particularly sensitive to skin cancer, I'd recommend maybe getting those. And then having a routine skin exam by yourself or your doctor. So how do you do a routine skin exam? Well, there's one of the best ways that I like to do that. And I'm trying to pull up my version of it right now. Is a free app through you can get it at least at the Apple Store. I don't know about Android, but it's called Skin Check. Yes, it's from the University of Michigan. No, I'm not paid to tell you about it. I actually learned about this when I was in St. Louis, not when I was here in Michigan. But it's a free app, my favorite kind. Doesn't cost anything. You don't put any of your own information in there whatsoever. And I'll try to show it to you just a little bit here. So, I mean, I just have the app. I'm going to put it up here, and it comes up saying, the light's probably not going to help very much. But you don't put any of your personal information in here, and you just say to start a full body survey and the new body survey and begin the survey. So then it's going to come up. Yeah, let me see if I can pull this down in terms of how bright it is, see if that helps. There we go. So you end up with a person here, and what you need is a chair, and you need an assistant. And what you do is you just say, okay, we're going to take a photo here, and it basically gives you a chalk outline of a person there, and you try to match that person inside the chalk outline. Then you take a picture, and then you go back, and then you go to the next chalk outline, and you take a picture, and then you go back, and then the next one for the legs. And just to show you this a little different, obviously that one's of a leg. Um, and then when you swipe to the right, come on, there we go. Now you got the back of the person. You swipe to the right again. Now we got the person to the side profile with their leg up. And that's where you use the chair. You put your foot up on that chair there. And then you end up taking the photograph. And then again, it gives you the chair, sorry, I'm supposed to turn it sideways like that. And it gives you, the person's butt there and then their leg coming out like this, and the other leg down. You basically try to fit them in the chalk outline. Um, sorry, it's not liking me. There we go. And then you end up doing the other side. You end up doing the head. You end up doing under the arms, the top of the head, and then the feet. So once all that is done, then let's see, whole body. Apologize. There we go. Then you're going to come back to the beginning. At the bottom here, it says set exam frequency. You click on that, and you can change this to every 30 days all the way up to every 90 days. And what this does is it just reminds you. It basically gives you a notification saying, hey, time to do your skin check again. And then you can take the pictures again. Now, this app is not going to tell you if you have skin cancer. I want to be very clear about that. What this app does is it shows you how to take photographs. It reminds you to take photographs, and then it allows you the ability to check between those photographs and see if anything is changing or anything is new out there. So I don't want you thinking that this thing will diagnose skin cancer for you. This is just a way for you to be monitoring and say, I don't remember if that skin lesion is actually bigger. And then you have pictures to compare it to. One other thing I really do like about this is in the middle one, it says skin lesion need recheck. So if you have a specific spot you're worried about, it gives you this little voodoo doll. And you can just hold your finger down and it'll land a pin right in there. And when that's the case, then it'll say steps for monitoring a new lesion. But you can take a picture of the spot. Let me get this out of here. And then later, when you are going to check again, this being a pain in the butt here again. Come on, no lesion available. I don't care. Cancel. Fine. Anyways, then next time you go back, you can make sure you're taking a photograph of that spot because it'll be in that little voodoo doll, and you can check and compare, the skin spot again. Now, the one thing I will say about this is if you're taking a photograph up very close so that you can't see what's going on with the rest of the skin, this is most common on the back. If you're taking a picture in the middle of the back and you're relatively up close, you really lose perspective of how big something can be because you have nothing of reference to it because it's all taken up by skin of the back. So if that's the case, then what I recommend is getting something of consistent size, something like a pencil or a penny or something like that, and just put it in the field of view. So that way, when you take a picture of it, you can compare that mold to that penny or that pencil. And that way you've got, or still a tape measure or whatever. But you want to have something to compare it to be able to say if it got bigger or smaller. Um, let's see think that's most on that. So let's say you have a reason, want to get it checked out. You can obviously go to a dermatologist. This is what dermatologists do, although a lot of dermatologists that I talk to now are more doing what I call beautiful people medicine with the Botox and the lasers and things like that. The skin cancer stuff doesn't pay as well as cash, apparently. So a lot of these things are falling back to the primary doctor, and your primary doctor should be able to help you a good deal with this. So usually you can get into see your primary doctor faster. I know that's not always the case, unfortunately. But as a primary care doctor, I definitely too strive to get my patients in quickly. Many can actually take care of you faster. By that, I mean a lot of them can make the diagnosis, and you'd be surprised the number of primary care doctors that can remove these type of lesions without sending you to a dermatologist. I was in a clinic previously where I was working with another doctor who really didn't do that type of thing, but so they would just send them all to me, and that way you didn't have to go see the dermatologist. And again, we could take care of those things faster. It generally costs less to have a primary care doctor do it than a dermatologist. Most people talk about paying copays, but usually procedures, there's what's called co-insurance. So you end up paying, I'm just making a number up, 20% of the bill. And so if that bill is, 10% less, then you're paying 20% of 10% less. So you get to save a little bit of money. And there's also the facility charge that sometimes dermatologists end up charging because they have a surgical suite or something like that. Some family medicine doctors end up having to do that as well, or they do that as well. It really depends on where you end up going and the company that that they're involved with, or if they're a private doc, or and where it's being done. You can have a colonoscopy, completely different talk, in an outpatient surgery setting, or you can have it in the OR at the hospital. And because of where you end up getting it done, they end up charging different amounts, despite the fact it's the exact same procedure. So my point there is just, you want to make sure that that's something you pay attention to as well. If for some reason you can't get in to see your primary doctor, or you can and they can't get you in to see a dermatologist, come see me. I'm happy to take a look at it, and I can manage your skin, take care of your skin stuff. I'm not saying you have to by any means drive out to Saline to see me, but I'd love to see anybody for that type of thing. I really enjoy doing that stuff. I actually ran a procedure clinic in Jackson for 5 years for the residents, teaching them how to do these types of procedures. And so I have a lot of experience doing this. So if you did come to my office, like I said, you get an experienced exam, and I do use the dermatoscope to try to make sure that I am not removing lesions that don't need to be removed. It gives me extra reassurance on lesions that are maybe a little questionable looking to the naked eye, but under the microscope can look entirely normal. And that can mean I can leave you with fewer scars. I can do liquid nitrogen if you need it necessary, which is basically destruction of the lesion. And I can do a variety of biopsies. So the punch biopsy we talked about already, that's just sort of a sampling, 3 millimeter circular lesion, circular piece taken off. There can be a shave biopsy. That's when you use a scalpel and you just sort of scoop out, try to go just underneath the top layer of the skin, so you're not leaving like a big cavity or anything, although you can do a biopsy that way as well. Dermatologists do that on a somewhat regular basis, called a saucerization. They sort of take a big deep scoop out of there. An excision, that's when you use a scalpel actually, and you make a little football shape, and then you end up sewing that one back together. That's the biggest difference there, is that one has to be sewn together. The shave one is just usually a triple antibiotic, Vaseline, and a bandage. And then, I end up working with the pathologist to make sure that, as I mentioned for my friend that had that problem with what I refer to as loafing, try to make a mark in the most concerning position within that lesion based upon the microscopic view I had, so they can make sure they cut through that spot specifically to make sure they don't miss that raisin in the bread. And I don't have a lot of pride from a standpoint if I see something I can't take care of. If you have a big goomba on the tip of your nose, I'm going to send you a plastic surgeon. I'm not trying to be a cowboy and make something amazing happen in a clinical setting. There are times when you need a specialist. There's times when you need their expertise. You need the equipment. You need the monitoring they can provide. And if that's the case, I have no shame whatsoever. I will send you to a dermatologist and let you know, or send you to a plastic surgeon and let you know, because there's things that they can do that I definitely cannot do, but I can do quite a bit. Per se, 80-90% of the things that walk through my door, I take care of. Someone wanted me to make it simple for them, so I made this first grade version of it. See spot change, then see doctor, because we don't want to see fill spot kill. So just a little bit about me and where I'd rather be right now, which is Hawaii. I went there with my wife for our wedding, for our honeymoon 20 some years ago, and actually went back to my mom here recently because she always wanted to go, and I had the opportunity to take her, and it was lovely. So at this point, I am open up to any questions you guys might have.
Excellent. Okay, Dr. Moore, can you hear me okay?
I can hear you just fine.
Okay, so I'm going to start running through the questions you have.
Sure.
So this person is asking why, when a person is diagnosed with melanoma and it's removed, do they not do an MRI and or a CAT scan to make sure they got it all?
So skin lesions, unfortunately, so let's talk specifically about the where the melanoma was first. If you remove the melanoma and then you end up doing an MRI or a CAT scan, it's not going to see anything because you removed whatever it was that was there. So it's not likely to show up very well. In terms of doing a full body CAT scan or MRI, looking to see if it's metastasized or not, um, the the treatment that is provided for somebody in terms of melanoma is not graded so much on where it has gone, but how deeply it invaded the skin. So when you stage somebody's cancer for melanoma, it doesn't matter if it's gone somewhere else as much as how much it's invaded. Because how deep it's invaded leads to how likely it is to have spread somewhere else. And so that's how they stage a melanoma in general, is just by depth of invasion. If they think it's gone out, they can do a CT or an MRI. But I have been in on cases where, in surgical cases, where somebody had been obviously was not doing well for some reason. They weren't sure exactly why it was. They did CAT scans and MRIs of their abdomen and pelvis and their chest. They did not find anything, so they did what's called an exploratory laparotomy, which is, when they basically, inflate the belly with air and they put the tubes in, the one through the belly button and two other sides, and the inside of the belly was just scattered with melanoma, and it did not show up on a CT or an MRI. Those types of tests are not incredibly accurate because it tends to be a lot of very shallow lesions, not like a big chunky lesion that can show up. And so it frequently will miss things, and it leads to the words I'm trying to find, a reassurance that is false in terms of the fact that things being better or not. So we treat based upon the depth of the lesion, and then if there is metastatic areas, we might go looking further to see where it's at that time. But initially, it's not the first line of diagnosis.
Okay, and when they do remove, maybe you or a dermatologic surgeon, do they actually scan and they continue to remove until they feel comfortable that they have removed?
Yeah, it's a great question. So in general, what we end up doing is we look at where the lesion is, and I'll end up looking with my dermatoscope because sometimes you can have little fingers that go out a little further than where the lesion is. Um, and the standard is for non-melanoma skin cancers is we take 2 to 3 millimeters on each side of the furthest area that we can see that skin cancer being. So we make sure we're getting everything that we can see plus a little bit, and that really gets the great majority of the skin cancers that's there. And like I said, since most of the non-melanoma skin cancers are locally invasive, if you just take that little bit extra skin, the great majority of the time you got everything. And then you end up sewing it back together and you send it off to the pathologist. Now, if the pathologist looks at it and says, you know what, you missed a little piece over there, it's not that big of a deal. We can go back and just take a little bit more. It tends to be a very small sliver on top of the scar you already had. Of course, we don't want to do that, but we can do that and remove it again and just sew it back up. And it's a relatively so it's an easier procedure than the first one you would have had done. Ideally, it's not done at all, but there's a balance between taking enough skin and taking too much so that you end up, having larger scars or cosmetic issues. So we try to make sure we take 2 to 3 millimeters on each side of the lesion that's there.
Okay. Is a red mole at a higher risk of becoming cancer than a black mole?
No, no, not necessarily. In general, red ones tend to be blood vessels, and black ones or brown ones tend to be pigment in the skin. Both of them can potentially be cancerous. But the red moles are, if be very generic here, they're less likely to be cancerous than the other ones are. But if they were bleeding, itching, things like that, they can cause symptoms as well. I would still probably take that one off or freeze that and cause it to basically die, involute, and the new skin grow in, depending on where it is.
Okay. We talked a lot about sunscreen. Do you
Yeah.
recommend sunscreen for a long drive? And this person said, I find in the summer, it seems that the arm or side of the face gets a lot of sun exposure through that car window. What are your thoughts on that?
Yeah, that's a great question. So in general, the glass does a very good job blocking UV light. So usually you don't have to worry about it very much. You might feel very warm if infrared light, which is on the opposite side of the spectrum, visible spectrum is UV light. So generally people don't get sunburned sitting inside cars when the windows are up. If your window is down, then absolutely I would be putting sunscreen on that, at least that side of the face and on that arm. If you look online, you can Google, trucker, sun exposure or something like that, and you can see that the left side of their face and arm looks pretty rough, and the right side looks pretty good. That's because they had their window down and they drove, and the sun just kept pouring in that side. Now, if there was a problem with the windows not blocking sunscreen, the UV light, then the other side of his face and his other arm should be looking bad too because it would have been coming in from the front of the cab. So it goes to show that when you're driving, as long as the windows are up, you're pretty protected.
Okay. The next person is allergic to the sun. So they say it's polymorphic light eruption.
Yeah, that's a tough diagnosis.
They blister and burn at the beginning of the summer season until their skin gets used to being in the sun.
Mhm.
Does that make them more prone to skin cancer because of that allergy?
You would be more, well, not the allergy itself, but the fact that there's blistering and things like that, a strong reaction happening in the skin would put you at somewhat increased risk for skin cancer. That does not mean you're going to get skin cancer. That just means that you're a person that you would have to have what we say is a higher index of suspicion, meaning if I see a spot, I'm going to be a little more concerned about a spot on you than I am going to be on, some of my family that is can tan very, very easily. To say maybe I want to biopsy that or look closer at that, at least with the dermatoscope, if nothing else.
Okay. I have had freezing and a biopsy on my face. Will these lesions come back again?
Unfortunately, well, can those lesions come back? They can always come back. One of the risk factors of doing a procedure like a freezing or a removal of a lesion, always, and at least I tell people, there's a risk of regrowth. I always say there's risk of bleeding. Of course, you're cutting the skin. The risk of infection because you're damaging the skin and bacteria can get in. Risk of scar because scars happen, and risk of regrowth if we don't get the whole thing. But that being said, you could do all the right stuff and remove the whole thing, but the skin just to the side of the spot you took off or on the other side of the face or whatever was exposed to the same amount of sun or chemicals or whatever else. It has the same genetics as the spot, this other spot right next to it, and so you could get a skin cancer in the same spot or a precancerous lesion in the same spot that's not related at all to the one you had, but it just happened to show up because it got all the exact same exposure and risk factors.
Okay, and we have someone who had chemotherapy, I assume, for a different type of cancer in another part of the body, but it actually removed the AK away from their face. Uh,
Yeah.
will that grow back in the same location once chemo is done, or
Probably not, but it can grow back, or it can grow, other spots. So I have some patients that come in that just have, looks like God took a little paintbrush and flicked it at their head, and they got actinic keratoses all over the top of their head. So it is possible for it to come back. And obviously, you would not have gone through chemotherapy just to remove that actinic keratosis. Chemotherapy can work for skin cancers, but just because of the fact that we have localized treatments that work and don't cause systemic problems, we prefer doing the localized treatments. So I'm very happy that went away. I'm sad that you had to go through everything else to make it go away. But the chances are that that potentially could come back, but it also can just new ones can pop up other places. It doesn't unfortunately fix the years of sun or other problems that may have put you at risk for getting those spots.
and you talked about liquid nitrogen as a treatment for those as well, correct? Um,
Liquid nitrogen can be used. We don't use it very often for treatments of cancers. We use it for precancers and warts and other things like that. For treatment of cancers, it tends to be, well, first off, it can be, when I treat actinic keratosis, I spray it for 5 or 10 seconds. It's uncomfortable, but it's not bad unless I'm doing many spots in around the same area. If I'm treating a skin cancer, I'm freezing that lesion for at least 30 seconds. So I'm spraying it for 30 seconds with something negative 300 degrees Fahrenheit. So it's cold and it hurts. And it feels like someone's pinching it really hard. It's so cold, it feels hot. And you're going through that for 30 seconds. And then we let it thaw. And then we repeat it 2 more times. And then I have you come back again and we do it again. It's pretty uncomfortable in general. And if you do that much damage to the skin with the freezing, it's really likely to scar. I use it on only very, very specific situations where so we can't do the surgery or the patient really does not want to have the surgery. There was a gentleman who was on hospice who didn't want to have surgery, but it was the skin cancer was the melanoma was causing him problems. In terms of odor and things like that, so we ended up using that treatment just as a way to take care of things. It's also not quite as effective for some skin cancers. It can be, but it can be effective, but it's not as certain as just removing the thing and taking it off and not having to worry about it again.
okay, and someone is asking if liquid nitrogen is something that can be bought sort of over the counter and used at home, or is it
It,
only?
Not over the counter, no. They do have those freeze away things that you can sometimes get Dr. Scholl's freeze away that they say to use for warts. I think those get down to minus 20 degrees or something like that. And those can be okay for warts and for some other spots that can be on the body as well. But in terms of skin cancers in particular, I definitely would not use that on skin cancer. It's not going to get cold enough or deep enough to be doing anything for those.
Okay. Um, you talked about Vaseline very briefly, and this person is asking, could Vaseline cause cancer?
In general, no. It's just Vaseline is pretty darn safe in terms of using, at least topically. I mean, I'm not saying I would like to eat a bunch of Vaseline or anything like that. I don't know if that'd be bad or not. But the in terms of on the skin, it's a petroleum product. But then again, so is triple antibiotic ointment. It's just inside a petroleum product. So bacitracin and triple antibiotic ointments and things like that. The what helps the skin heal after abrasion or something like that. You always see the photographs on TV. They're like, this one we use nothing, and this one we use the triple antibiotic ointment or whatever. And look how much faster the one we use the triple antibiotic ointment on worked. Well, it's not the triple antibiotic ointment that did it. It's the fact that the skin was kept moist, and so the new skin cells could slide in and grow. And so by putting the Vaseline on there, if you compared Vaseline and the triple antibiotic, they'd actually heal at the same rates. So the Vaseline is just Vaseline, and I would say, and the triple antibiotic is basically Vaseline plus the other drugs in there, which is not bad. But the only problem I have with triple antibiotic ointments and what have you is some people have allergies to those antibiotics. And so if I can avoid a skin reaction to a spot that I just removed, I'd like to minimize that risk. And as long as you're taking care of the skin, the surgery site with a Vaseline and a bandage and changing it twice a day, generally that's good enough to help prevent any infection and actually helps heal things up faster with less scar.
Okay. This person says their father had skin cancer and they have many spots, including AK spots. They're
Yeah.
wondering if there's a good way to have them all scanned or monitored beyond just a visual annual check with a dermatologist.
So that's a bit more challenging. It is definitely possible. For patients that have multiple familial nevi moles, like it sounds like you might have, generally I send those patients to the University of Michigan. It's because the University of Michigan has photography and computer software that can help monitor those. And so that way the computer can help, keep sizes on things and keep records so they can use AI, for lack of a better term, to be able to say, okay, we compared all these 100 moles, and these are the ones that are looking different based on the parameters that lead to skin cancer, whether it's color or size or shape or what have you.
Okay. And there are some questions about the app you shared. I will include a
Yeah,
link to download both on Android and iOS in the follow-up email.
yeah, it's Skin Check, so University of Michigan Skin Check. It's all one word.
Okay. Do skin cancers on the scalp look the same as those on the face, generally speaking? And how common are cancers on the scalp?
So yeah, they tend to look the exact same, and that is one of the more common areas to get it because of the amount of sun that we end up getting. I would say that they're fairly common up there. Skin cancer is the most common cancer in humans. Skin is one of the largest organs of the body, so it sort of makes sense that would be the case. But because of the amount of insults we end up getting with UV light and the like, it is one of the most common cancers of the body. So it is one of the reasons we keep an eye out on looking for it. And then, of course, the scalp is one of the areas that gets the most sun. So we do keep an eye on that as well. So yeah, I would say it's of the areas to get cancer is skin cancer is one of the higher likelihood areas to get skin cancer.
Okay. Do you have a special recommendation for a sunscreen for kids 5 and under, or do you have ingredients that should not be used on children 5 and under?
There's no ingredients that can't be used for my kids. My kids sort of had sensitive skin, and a lot of younger kids do, and so that's when I more reach for the titanium dioxide or the zinc oxide ones. And for the zinc oxide ones, you don't have to get the version that is like the prototypical 1970s, 80s lifeguard that had that big white paste on their nose type of thing. It can be something that actually absorbs very well in the skin. It can be pigmented, so people don't have to look all pasty and everything. But for kids, I generally would go more for a zinc oxide or titanium dioxide based ingredient. I don't think the other ones are necessarily bad. I grew up having those other ones applied to me, and I think I turned out relatively okay. Just don't ask my sister. But it's it's all of them are considered safe. It's mostly the irritation that can happen if you have a sensitivity to the chemical versions.
So you
That's
don't,
not to say you can't have reaction to the mineral based versions as well, but the chemical based more version is just a little more likely to do so.
and do you have concerns about some of the chemicals being absorbed into the body or through the skin?
Yeah, People have a lot of arguments, especially about micronized zinc and things like that. I always find that a little bit interesting that people are talking about taking extra zinc by mouth in order to be support their immune system, but then they're worried about the zinc on the skin. I know they're not necessarily the same formulations and things like that, but I don't personally have any major concerns about using zinc oxide or the other chemicals on my skin.
Okay. And how about those spray sunscreens? Those are so much easier for kids, but I've heard they don't work as well.
It's harder to get them to stick, and trust me, I definitely use them on the top of my head because it's can't get the little hair I have on there. I don't want to be matted to the top of my head, so I generally spray that on, then I'll put on a hat on top of that. But no, I definitely use those. The issue with those being is that you sort of have to make sure you get really good coverage with those and rub it in. And sometimes, depending on if the kid is cooperative, you got to do it a second time, and it can get in their eyes and what have you. So you do have to be pretty diligent on that stuff. But it can be effective if used as is directed. But if I had a preference, most of the time I'm going to use the cream.
Okay.
But I would say that's in an ideal situation. But compliance is incredibly important. Like I said earlier, if you're going to have SPF, 90, and it's going to you're going to be able to put it on. It's going to protect you really well, only for about 2 or 3 hours. Then you have to reapply, no matter what strength you put on. You have to reapply every 2 to 3 hours. But you put on 90, but if it's that big gloopy stuff that just makes you feel all pasty and yucky, what's the chance of you putting that on again in 2 or 3 hours? Not so great. So I'd much rather you use something that's somewhat inferior product that you're going to use every 2 or 3 hours than a superior product you can only apply once. Because that superior only applying once means that you're not protected the rest of the day, and that's not good enough.
Okay. And we have someone who says they're sensitive to almost all sunscreens, even the sensitive skin ones.
Yeah.
Supplement with,
There's not a lot of recommendations I have for that in terms of sunscreen, unfortunately. I'd be encouraging that person mostly to find shade using wide brimmed hats, long sleeve shirts, looking for the long sleeve shirts that have a that are purported to help block the sun's UV rays. That's more what I'd be looking for in that situation.
okay, I know swim shirts are big. They were at Costco last summer. So
Yep, yep. My wife insists our kids having those because they were they had the skin that she did.
yeah. Okay. Um, this is a great question. What does precancerous mean?
Precancerous, that's a great question. So generally something does not go from normal to cancer. There are steps along the way. Our body does a very good job trying to help prevent things from turning into cancer, and it tries to find things when they start to become slightly abnormal and then basically kill it so it doesn't get turned into cancer. And those are called T killer cells within our white blood cells community that go around and do that. They try to find cancer and kill it before it turns into something bad. Unfortunately, they don't always work. They actually, if we didn't have those, people who have genetic mutations, they don't have those T killer cells, or they take chemotherapy agents to help with their rheumatoid arthritis or something like that. They have because we're blocking those cells from doing their job. Those people have more skin cancers. So, anyways, there's not just one flip that has to be switched to turn into cancer. There are multiple things that have to happen in order for something to turn into cancer. And so, as it's on its way there, and we see those abnormalities, we call those a precancer, but they're not cancerous themselves.
Okay. If you're diagnosed with melanoma, how effective is immunotherapy? And what is the difference between immunotherapy and chemotherapy?
That's a great question. Before we go too much further, it looks like my battery's getting low. For some reason, I suddenly disappear. It's not because I want to, it's because my computer died and I forgot to bring my cord. So chemotherapy is basically a chemical that is designed to try to kill something. And for melanoma, that can be somewhat effective. Immunotherapy has been a relatively new thing, in which ends up basically trying to activate the immune system to help do that job of killing that area. And that has been effective in a different treatment. Whenever both of them can be somewhat effective, I should say. I don't want to oversell it for treatment of melanoma or other cancers. But any cancer can develop resistance. Basically, if you have 100 cancer cells and 99 of them are sensitive to this thing, but one of them is not, you kill all 99, but that one now it grows up and every progenitor it has the resistance to that treatment that you tried. And so then now you got to try to find something that will work on that one cell that now has become the new 100 cells. And so it's a challenge to sometimes find that. But the immunotherapy is a great adjunct therapy, something extra that we can try. And the more tools we have in our belt, the better.
Okay, I will ask one more quick question. So this person had melanoma in 2004 on their shin, and it was
Hmm.
had to have a skin graft. So now they've had changes in eye floaters in the left eye. The ophthalmologist found a spot on the retina. So
Okay.
just waiting. Does having melanoma on your shin or anywhere else on your body increase the chance that the spot on the retina could be melanoma?
It's not really the retinoma, sorry, the retinoma, sorry, melanoma on the retina. There's not major risk factors that we look at generally for that. Obviously sun exposure is part of it, but as I mentioned, you get melanoma between your toes. And if that's the case, sometimes skin exposure is not really a factor at all. So the fact that you had skin cancer once does put you at increased risk for getting a skin cancer. And even if it's on the back of the eye. But that I would say with the melanoma of the eye is so uncommon that I would say that even with that skin cancer, the first five things on that list of what that could be on the back of your eye are probably not skin cancer at all. Now, I would definitely have that on my list, but I would not be I'd be concerned enough to make sure you're getting checked out, but I would not lose sleep over it at this time.
Okay. And does melanoma spread if you pick at it?
Well, it can spread if you don't pick at it. So it just, it basically grows deeper in the skin, and once it gets, beyond its natural boundary where the cells normally were, it gets worse. That's when it starts to potentially metastasize. Picking at it's not going to make any difference for it from that standpoint. It can make it that's a little more an irritated spot, and hopefully it'll make you go and get it checked sooner. But that doesn't mean that it'll make it spread faster.
Okay. And I think there was one more about they were talking about blood-filled spots on the skin. Are those a concern?
Well, yeah. So if there are red spots that just look like sorry, look like blood vessels, just red, you push on them, they don't go away. They could be raised, they could be full. Those tend to be, and I can't say 100% of the time because I'm not looking at it, but those tend to be just a little conglomeration of blood vessels that have maybe a little bit of scar tissue around them so they can feel firm and raised. And those tend not to be cancer. They tend not to turn into cancer. They're things that can be treated with a liquid nitrogen spray, but it really depends on how many there are and how big they are and where they are, and and your preference and things like that as to whether if you should do anything about it.
Okay. Well, before we lose you, thank you so much for this wonderful presentation. It was very informative.
Great.
Of course, I think the moral of the story is get your skin checked, and your primary care physician is a great first step, especially if you're having those annual exams, to include your skin check in your typical physical. So Dr. Moore is accepting new patients. I will share his contact information as well as a link to schedule with him. I will also share the app that he spoke about, and then we'll also share that fun graphic for the ABCDEs of melanoma. So look for that to arrive in your inbox. Thank you so much for joining us, to the people who were able to make it tonight, and we appreciate you, Dr. Moore. Thanks for sharing this important topic.
Of course, happy to talk. I hope you all have a wonderful rest of the winter and go safely into the upcoming warm weather.
Sounds good. Thank you.
Welcome.